So this is a series of discussions that we're having with healthcare professionals about their experiences of helping people make decisions about to go on intravenous therapy or not intravenous therapy. And we know that there are different types of drugs that are involved here. So not to talk about the specific drugs themselves, but the practicalities. We've got Sain, who's a nurse specialist from Sheffield, and Carl, nurse specialist from the Brompton Hospital in London. Carl, can I just start with you? Your experiences with people's concerns about what are those concerns, and what are some of the really helpful things from your perspective, from your experience, to get over those?
Okay, patient concerns stem from many aspects. One, other people's experiences of intravenous therapy or their perception of living with pump technology that will be complex, to the risk of line infections and side effect profile and management of that. All of these factors come into it, and also living with it in terms of day to day. Can the family cope? Can I cope? But they are realities of living with pump technology and intravenous therapy, but I think that's balanced out by the good effect that you can see with intravenous therapy. And I tend to use patient stories, as I call them, because I think they give a reality check and hopefully balance out the negative aspects to the positive aspects. So when you say
patient stories, in practice, what would that mean?
All right, so an example would be one of my patients that I started on therapy walked 80 metres, and I know it was an 80-metre walk because I actually did it. Mm-hmm. She couldn't have done any more. Within a month of therapy, she was walking over 200. And by the end of 3 months, she was walking 380 metres, and now goes to boy band concerts. And she's about the same age as you, Iain.
Boy band concerts.
So it's a bit embarrassing.
How old is she?
She's in her late 40s.
Thank you. Sain, what about this idea of using examples? Because these patients are, by definition, are potentially quite sick people, because that's the reason for the intravenous therapy. What are your experiences? Are they very similar to Carl's? Is it a common theme, this anxiety of can I manage the pump? And how would you deal with that?
Yeah, I'd say it is very common.
Mm-hmm.
And so what we'd normally say would be that they would be in for any length of time where they're comfortable and fully trained. They'd have a training session with us every day while they were in, till they felt competent and comfortable to go home with their therapy. So
there's no like, you come into hospital and you've got to have this done in 5 days and then you're out. So the pressure of time is the individual, isn't it?
Yeah. There's no major rush. It's a big decision to make.
Mm-hmm.
And people can go home and then discuss with their partners and family and friends, and then make the decision from then. There's no major rush with it. It's too big a decision to make.
What sort of questions do you think, and Carl, you can chip in on this one, this discussion with partners and family and things like that, what would you envisage or encourage people to talk about when they talk about intravenous therapy? Discuss what specifically?
But the practicalities of actually living with it, how they would manage and cope with situations of unpredictability where a pump started to malfunction in the middle of a supermarket, and the realities of how they would deal with things together. I also focus on people who are in a couple or in a relationship, that that they see that they can have normal relationships.
So this is one of the things I think in healthcare we talk about body image, which all sounds a bit technical, and because what are your thoughts and experiences, Sain, with a pump? Do you think people really, that's a real anxiety with them, or because just because somebody's sick doesn't mean they don't have normal needs for affection and intimacy?
Yeah.
So it's okay to have those discussions, isn't it?
Yeah.
Sometimes it's that sort of silent part of the condition, is it? We don't talk about this because I'm really sick.
Yeah, and I think that usually comes up maybe later on in the training and things, when the patient maybe gets to know you a bit better.
Mm-hmm.
And things like that do come out, and they're having a line put in their chest, and having to wear a pump every day. It's a big issue.
Do you think, Carl, you talked about patients, so you can anecdotally tell people a story like the lady is saying going to boy band concerts. What about patients having the opportunity to speak to other patients who've been through that process? Good thing, bad thing?
No, I think it's a good thing if it's what a patient wants. And We only started somebody on intravenous therapy only about 3 or 4 weeks ago, and felt that she did not want to have any engagement with somebody that's already on therapy. The other side of the spectrum is that there are patients who think, no, I really would like to speak to somebody because I want to know what it is like living with this treatment. Because as much as I can help them make the decision to go on to that therapy, I think the reality sometimes has to come from somebody who knows, and that is somebody else who's living with it.
Okay, if somebody's contemplating, and in this case we're talking about intravenous therapy or any sort of treatment for pulmonary hypertension, we often talk about and trying to have conversations about expectations of the therapies. What do we mean?
What's their goal? What would they like to get out of going through this? And then again, I think when we do discuss that, we then have to discuss if they don't reach that goal, what happens then? Would they be happy to come off of the drug, or how would they like to go about that? And I think that's a very important part of the initial discussion, really.
Because sometimes people, like with any treatment, and intravenous is quite particular because it involves quite a lot on that individual's point of view. Unfulfilled expectation can be quite a challenge.
Huge, but then we have to listen to the patient's needs and wants at that stage if we're not reaching their goals. Because is this a bridge to transplant, or is this a bridge to symptom control? And I think often intravenous therapy is considered a bridge to transplant, but most of the time it's symptom control and giving patients that level of exercise and ability that they've lost.
A bit of improving, well, significantly improving quality of life, isn't it?
Yeah.
Yeah. Sometimes there's often concern as well about potential side effects of any drug, okay? And when a drug's being given intravenously and continuously, that's very different than taking a tablet. If somebody gets lots of side effects from it, can they be managed or not?
Yeah, I think they can. I think it's our responsibility as healthcare professionals within the pulmonary hypertension team to intervene quickly. Because I've seen it where a patient actually felt that the side effects were so great that he wanted to stop his therapy. However, on getting on top of the side effects, he bounced into clinic and was actually the wellest he'd been in many years. And I think getting on top of side effects begins on the initiation of therapy to make sure that those medications are prescribed ready, so that you don't wait for somebody to have nausea. You don't wait for them to have the diarrhea. They're there, and you wait and you give them the medication that will help ease those symptoms until everything adjusts and everything returns back to normal.
It is important that patients feel comfortable about discussing adverse side effects, that, you know, rather than just say, I always feel sickly, so I'm not going to say anything. It is important, is it, either to write them down. Sometimes these side effects come at certain times of the day. They can't be managed if they're not discussed.
Yeah, so it's good to keep a diary of things like that, and keep an eye on things like that, and let your specialist team know, and then it can be tackled and looked at.
And I think the important thing is, if you prepare them for these side effects, that they are probably likely to happen, and you reinforce the fact that we can do something about it. I think that gives the patient some empowerment. In my practice, I would say I encourage them to say, take your anti-sickness tablets on a regular basis, see how you go, and stop after a period of time to see if those symptoms have abated, and if they have, all well and good, and if they haven't, to carry on taking the treatments.
Is it okay, do you think? I mean, it's a big question. Patients discuss with the specialist doctor, specialist nurse, etc. in pulmonary hypertension. A patient making that decision, well, thank you very much, about intravenous therapy, but to say, I don't want it. Is that okay?
Of course it's okay. Yeah, it's patient journey at the end of the day, and they're how they feel. They're the expert on themselves, so they should be able to make that decision if that's how they feel.
What do you think, Carl?
As their clinical nurse specialist, I always respect their decision. I always say it might not be the decision of the team, and I think some healthcare professionals get frustrated by the fact that they won't go on to this therapy because they believe strongly that it's going to make you better, but nobody ever knows. And I think it's always got to be in the time of the patient and not the time of the healthcare professional.
So that thing about time as well, isn't it? The initial discussions don't necessarily mean, and you must make the decision now. It's again, individuals and the family need to feel comfortable about considering these things. If you go on intravenous therapy, and for some reason, whatever that could be, it just does not suit you, can you come off it?
There was always this myth, I think, of 20 years ago that it was a treatment that can never stop. You know, and 20 years ago there weren't any other medications that could hold back this condition from progressing. But I think if a patient decides that the therapy isn't for them, that they can't ultimately cope with it, then of course we must stop it. But with the knowledge that they're making a choice that will probably bring on the worsening pulmonary hypertension in a much quicker time.
But then some intravenous drugs, like all the drugs that we use in pulmonary hypertension, don't always work in all people, do they? That we don't all respond to all drugs. So sometimes going on intravenous drug, it just doesn't work for everybody, does it? Like paracetamol doesn't always work for everybody's headache.
That's it, and I think that's a good place to start with initial discussions as well. It might not technically suit them, and it is an option to come off if needed.
Can I just add to that,
Yeah.
though? That is part of the frustration of nursing and caring for people with this condition, is the frustration behind it, not just for the patient, but for us as healthcare professionals when a treatment doesn't seem to be working. Because you want that person to get better. Because that's why we do the...
And as you said, I mean, this is
Job
about when you say get better, improve symptoms,
Yeah.
improve quality of life,
Yeah.
perhaps improve what you can do on a day-to-day basis.
Go
And that,
back holidays, back to work if that's what's right
if
for them.
people are in that position, I mean, it's about it's the expectation, isn't it? But those expectations being realistic. None of the treatments we have in pulmonary hypertension at the moment completely wipe out all the symptoms for most people. There will always be exceptions. And they're really interesting and quite interesting individuals to have conversations with. Some people with pulmonary hypertension on treatment almost seem to be to respond so well that they are back at work full time if they're still of working age or whatever. But the aim with all the treatment we do is to live as normal life as possible and to adapt.
Yeah.
Sometimes it's that ability to adapt, isn't it? And often that involves really honest conversations with all round, isn't it? If somebody goes on intravenous therapy, how long do you think is a reasonably good time? Because sometimes, you know, people need to stay on drugs for a certain amount of time to know if you're getting a benefit or not. What conversations would you have with people at the initiation, the start of treatment, to say, for us to understand and for you to understand this is working or not, we need to think about for what period of time, the next month, the next 3 months, 6 months, what again, from your experience?
So initiation of therapy, there's very close monitoring. We'll see them after the first month. We'll up-titrate quickly if we need to on the dosing.
Up-titrate, push up
So
the
that's
dose.
going up, increasing the amount of medication that we're giving.
That dose is very individualised, isn't there?
There is no standard dose for anybody. So
Okay,
it's,
so sorry to interrupt. So this idea, how long then? Would you sort of think is a time in which there's a healthcare team with the patient saying,
you know, if you want to go on a clinical basis, you'd want to see 6-minute walk tests increasing within at least 3 months. And you'd be looking and setting clinical goals from that perspective, but also setting patient goals for what their expectations. Are you able to do more? Can you do the hoovering? Can you walk up the stairs to your bedroom?
so very practical, really practical type things, yeah. 6 months is a good period of time, and
I
at that
think
stage,
so, yeah.
if these treatments are going to work.
None of these therapies work overnight. You know, some patients say my breathing is so much better even within 24 hours. But I think the textbook answer is you should see a difference within 3 to 6 months.
Would you agree with that, Michelle?
I would agree, yeah. We usually see patients after about a month as well, and keeping close contact. And usually by between 3 and 6 months we would know if the therapy was working or not, really, and if they'd reached the goals.
I mean, that's an interesting point, isn't it? So we're looking between 3 to 6 months. That seems to be what you're both saying. One of the final angst or concerns is when people go on treatment, and it's okay, you might spend 10 to 14 days in hospital learning it. And then the big thing is when you leave hospital and going home and feeling almost not having that security. How do you manage that anxiety, that worries, those concerns?
Well, I tend to start that at the beginning of therapy as well. Going home on this therapy is probably going to knock you for six. You're going to feel a huge emotional washover because you're going to be entering somewhere that's familiar to you, and walking through the front door brings emotions, tears, relief, because they're finally there. They're home on a therapy that has changed their lives completely. I think it's important that we prepare them on initiation of therapy, that these are the challenges of discharge for them. You don't put much emphasis in the first week of therapy, but you start to prepare them throughout their initiation journey.
Sian, anything?
I think, like Carl says, to start preparing the patients while they're in hospital, just with simple things like wearing normal day-to-day clothes and not pyjamas once they have the line in, so they can work out how to wear the pump, and having a plan in place that they're aware of, so they go home with their clinic date to come back and are aware that they'll get a call from the nurse specialist say in a week's time or whatever the plan is, can help as well. So, and
again, I think one of the things about specialist care in pulmonary hypertension is that there's always somebody available 24/7, isn't there, by telephone, and considering, and before they go on, is working out which questions and which are important to ring up about or to wait. So it's this preparation thing again, isn't it?
I think also one thing before discharge is that they have the right paperwork, that if they presented at some local hospital that wasn't familiar with their treatment, that they have a step-by-step guide for those healthcare professionals to deal with them and manage them until they can come to a specialist centre.
Okay, well, thank you very much, Carl and Sian, for that. This is the start of some conversations that we want to make available for people. So there's no absolute, I think the interesting thing from both of you is that there's never an absolute right and wrong answer to this, isn't it? And it's about taking time, being honest with the questions, setting realistic expectations. So thank you very much.
Thank you.